Welcome, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Roger Goldberg of Walnut Creek, California, Bay Area Retina Associates. Roger, welcome back to Retina Synthesis.
Great to be back here, Carmen. Thanks for having me.
So you've got exciting news today about Faricimab, reported for the first time at ARVO 2023 by you to a big crowd. And what it seems to indicate is that the anti-Ang2 inhibition effect has an important role in enhancing blockage of macular leakage. So let's talk. What did you find?
Yeah, well, so I think look, Faricimab has been around for a little over a year, and I think we're seeing increasing usage of it for both AMD and DME, and I think kind of anecdotally and in our clinics and in some post-hoc kind of real-world settings, we're seeing good effect. But one of the questions that always comes up is, well, is that improved efficacy and durability that we're seeing, is that related to just the increased molar dose of VEGF-A inhibition, or is that actually the Ang2 component doing something? Because Faricimab, as you know, is this bispecific antibody that inhibits both VEGF-A and Ang2. And I think it's been really hard to tease out, but I think this macular leakage data in diabetic macular edema that I was able to present at ARVO really does, I think, in a compelling way, point to the added benefit of Ang2 inhibition, particularly here in this analysis in diabetic macular edema. So what we did is a post-hoc analysis of the Yosemite and Rhine studies. And in those studies, as you know, it was Faricimab versus Aflibercept. And patients at baseline got a fluorescein angiogram. And then everybody, regardless of what arm you were randomized to, everybody got 4 monthly loading doses. And at week 16, everybody got another fluorescein angiogram. And macular leakage, although we don't typically kind of see it reported in the way that we see like central retinal thickness, the anatomy of on an OCT. We see that kind of more frequently reported in clinical trial data. And we know that OCT, of course, is the workhorse of our clinics, but macular leakage, it turns out, is actually a really important marker for vascular stability because, and again, we don't sit there and kind of measure it clinically in our own clinics, but the reading centers, thankfully, can analyze the clinical trial data. And for example, from the Ruby study, Justice Ehlers has done some nice work to show that reduction in macular leakage correlates with improved anatomic outcomes on the OCT and in terms of microaneurysm count on wide field angiography. And reduction in macular leakage actually also correlates well with vision improvement. So for every 1 millimeter decrease in the macular leakage area, there's about a 1-letter increase in visual acuity gain. And so the findings really highlight the importance of quantitative macular leakage measurements as a biomarker for diabetic eye disease. So what we did is we took all the patients, again, kind of in a treatment agnostic way, regardless of what drug they were assigned to, and we looked at kind of the distribution of how much macular leakage was left after those 4 loading doses. So at the week 16 angiogram, and we divided the patients up into 4 quartiles. Quartile 1 or cohort 1 had resolution of their macular leakage, less than 1 square millimeter of residual macular leakage. Cohort 4, that 4th quartile, had persistence of macular leakage, more than 10 square millimeters of macular leakage on the angiogram. And then we looked to say, well, just again, in a treatment agnostic way, does kind of moving patients from a persistence or high macular leakage phenotype into a low macular leakage, does that actually make a difference for patients? And it does. Again, looking across all the patients at year 1, if you were in the cohort that had resolution of your macular leakage, you tended to gain more vision and maintain those vision gains throughout year 1 versus the cohort 4 that had persistence of their macular leakage. And then, not surprisingly, if you were in cohort 1 with resolution of your macular leakage, you tended to be able to achieve a drier retina and maintain a drier retina over the course of the first year of the study. So, being able to move patients from persistent macular leakage to resolution of macular leakage after that loading phase, I think of as probably a pretty important marker for eventual success here in terms of vision and anatomy. So we then compared the Faricimab and Aflibercept treated eyes, again, looking at this head-to-head phase. And at baseline, before anybody had received any care, the groups were really well balanced. The median amount of macular leakage in both Faricimab and Aflibercept treated eyes at baseline was about 25 square millimeters. And there's a distribution curve, and those curves really overlap remarkably at baseline. When you look at how much leakage is then present at week 16 after those 4 loading doses, well, there's about a 50% reduction in the macular leakage in the Faricimab treated eyes. So 7.6 square millimeters in the Aflibercept arm versus 3.6 square millimeters in the Faricimab arms of the study. And then we looked at the actual distribution curves themselves and said, well, how many patients are we actually shifting from kind of cohort 4 down to cohort 1? Cohort 1 being the better one, resolution of their macular leakage. And here again, we saw very impressive outcomes, but there was a near doubling in the Faricimab treated eyes of the study in cohort 1, from 15% in the Aflibercept group to 28% in the Faricimab group. Again, so almost doubling the proportion of patients in cohort 1 resolution of macular leakage. And where are those patients coming from? Well, we saw nearly a halving of the proportion of patients in cohort 4, persistence of macular leakage, from 43% in the Aflibercept arm down to 26% in the Faricimab arms. So we're clearly shifting patients down the spectrum from more leakage to resolution of leakage, comparing Faricimab versus Aflibercept. Now, what's driving that? What's driving that improved macular leakage? Well, this is, I think, where we really see the benefit of Ang2 inhibition. We know from all sorts of preclinical data that Ang2 inhibition on its own leads to reduced vascular leakage, and even more so in conjunction with VEGF inhibition. But I think the best kind of comparator is when you look at the Photon study. In the Photon study, this was comparing 2 milligram of Aflibercept to 8 milligram of Aflibercept, high dose, what sometimes people are calling high dose Eylea. And you look at the difference in macular leakage in the Photon study after that loading phase, and both the 2 milligram and 8 milligram arms have the exact same reduction in macular leakage. There's no difference in how much the macular leakage has changed, 2 milligrams versus 8 milligrams of Aflibercept. So to me, this really speaks to, with Faricimab, it's not, any increase in the molar dose of VEGF-A inhibition. It's really being driven by the Ang2 inhibition, because quadrupling the Aflibercept dose doesn't really improve the area of macular edema. Similarly, we've kind of known this. If you look at the Photon just CST data, the curves really overlap during that head-to-head phase. There's no difference on the OCT anatomy. And in the READ-3 study, which was looking at quadruple ranibizumab or Lucentis, there's no difference in the central retinal thickness. So just adding increased VEGF inhibition doesn't seem to be making a difference in the anatomy or in the macular leakage. So it really does point, I think, to Ang2 inhibition. So anyway, that's kind of what we were able to share. I think we'll see more data and analyses coming out around macular leakage and the role of Ang2 inhibition. But I think it's a pretty compelling story.
Our listeners may not know a lot about macular leakage metrics, considering that all the clinical trials are centered around OCT. Was there an OCT correlate to these findings?
So So if you look in Yosemite and Rhine, and this has been shared, honestly, since kind of the day one of the top line results coming out. But if you look at the just the OCT curves, the central retinal thickness curves, there was a greater reduction, a better drying effect at the head-to-head stage with Faricimab versus Aflibercept. So we see that at week 16. You actually also see that result at the end of year one. As the trials go longer out, it's sometimes harder to compare exactly because there's differences in the timing of when the last injection has been given, whether the patient might be 4, 8, or 12 weeks out from their last injection. So sometimes it can be a little bit hard to exactly compare things later on. That's why I like this head-to-head analysis, because everybody's apples to apples. Everybody's gotten their 4 loading doses, and we're looking 4 weeks after that last loading dose.
So this is a reason to choose Faricimab over Eylea for the treatment of diabetic macular edema?
It's funny. I think it's definitely been very compelling to me, and I've been looking more now at the angiograms, and I think obviously we're not doing it in this forum, but I think what's helpful is just to look at kind of how much macular leakage is there at baseline, or maybe you didn't get the FA at baseline, but you're looking at the FA kind of after the first or second injection, whatever kind of you and in your treatment algorithm are doing an angiogram and diabetic macular edema. But definitely, I think you kind of look, and sometimes you say, hey, this is a patient that maybe they got 1 or 2 leaking aneurysms, parafoveal, and that's what the driver of their diabetic macular edema, and it's not related to kind of diffuse macular leakage. Well, maybe in that case, the patients will do well with any agent. But then you do the angiogram on other diabetics, and you really do see, not a wildfire, but a lot of hyperfluorescence there as the dye is leaking out of the blood vessels. And I think those are patients who will do well with Faricimab.
Well, this is exciting news, and renewed interest in fluorescein angiography, ironically, during a period of time where the fluorescein sodium agent is remarkably difficult to obtain, with one supplier left in the United States on this day.
The one advantage, and what we've started doing in our clinic, is the one advantage with ultra wide field angiography is you don't need as much of the dye. Yes. So you can, it used to be you take 5 mLs for one angiogram, which is what the vials come packaged in. But now you can actually get a awesome angiogram. And so we're using about 1.5 mLs for most patients, and we're stretching that one vial across 3 patients. And I think that is one of the benefits of ultra wide field angiography.
So just to recoup, what are your indications for fluorescein angiography in diabetic eye patients these days?
Yeah, so even before this, I think the other benefit, and why we've seen perhaps a little resurgence in diabetics in particular, is for the peripheral evaluation and assessment, because we know, for example, from the DRCR protocol, I believe AC, which looked at predominantly peripheral lesions, but there's just so much we can detect now peripherally. So on my diabetic, DME and kind of severe NPDR or worse patients, I'm always getting an angiogram at baseline. I want to have those baseline measures. I want to know what's happening in the peripheral retina, as well as what's happening now. I think this has kind of keyed my interest a little bit more into what's happening in the macula as well. So I tend to get it at baseline, and then, kind of depends on how I won't necessarily get one again at week 16 like they did per protocol in Yosemite and Rhine, but depending on how the patient's responding and doing, I often will then check another one maybe at the 6-month time point, and or longer if they're doing well, or but it's sometimes fascinating to see what's happening with that peripheral ischemia as well. Is that getting worse, or has it been stabilized? And that'll sometimes help guide my treatment too.
Is Faricimab your agent of choice now for DME?
Yeah, for sure. We have a lot. I'm in California, and so we have a lot of Medicare managed Medi-Cal and managed Medicare plans. So it's a highly, highly managed category. So I think kind of all things being equal, yeah, that's my agent of choice. But to the insurance companies, all things are not equal, and so we often have step therapy, both with Avast and sometimes actually double step therapy through Eylea as well. So it's not always kind of, physician choice and autonomy is, while still robust, is not as robust and as we might like it to be.
Well, this has been a very interesting discussion as a venerable standby. Fluorescein angiography makes a comeback as a knowledge producer and as a new agent that was widely studied and enthusiastic is obtaining a new role. Faricimab.
Yeah. Yes.
How about it?
So, and again, more to come here, I think. So.
Yes. Okay, Roger. Thank you. See you
Yeah,
back
great to be
soon.
here.
Yeah. Bye.